This conference will now be recorded.
Right, and then that's your camera. All right. Good morning, everyone. I'm Angie, and I'm the Director of Clinical Services with Humanity Hospice. And today we're going to talk about hospice care in the nursing home and kind of what the requirements are for each entity. So what hospice is responsible for, what the long-term care facility is responsible for. We'll talk about what the hospice benefit includes, and we'll talk about hospice eligibility as well.
Ask if everyone can hear you right now.
Can you guys hear me? I'm pretty loud.
Yeah, we can hear you. I can hear you anyways.
I'll leave the mouse over the other screen. Oh. No, it's not working. Okay. So the definition of hospice care, residents are entitled to hospice care by both the state and federal regulations. Regulations establish that long-term care is the patient's home. So hospice can be provided anywhere that the patient defines as their home. So it can be an assisted living, it can be an actual home, it can be the long-term care facility. It can also be provided short-term in the hospital under a level of care called general inpatient care. It's a program of care that's defined by Medicare and Medicaid that offers the patient and caregiver system and the family's palliative care. It's intended to meet the physical, emotional, and spiritual needs of the patients and their families facing end-of-life illnesses. The goal is to provide comfort to the patient by assisting with pain and symptom management and to enhance the quality of life for both the patient and the family. So in order to receive hospice care, the patient has to have a prognosis of 6 months or less, should their disease run its normal course. So that being said, some patients die much quicker than that. Some patients live quite a bit longer than that. You'll see that especially in long-term care with your Alzheimer's, dementia patients, maybe your COPD patients. Just because they live beyond 6 months doesn't mean that they don't qualify for hospice care. As long as they continue to have that prognosis, they will continue to qualify. Hospice is not about giving up hope. We want people to keep their hope up. They don't have to raise their hand and say, I'm ready to die, give me the DNR, give me all of this. I am done with life. They don't have to do that. So they can still have hope, but they need to have the understanding that it is a palliative focused care and not a curative focused care. There's benefits to both the hospice and a long-term care facility. We provide an additional layer of support to the long-term care facilities and the patients. We provide additional eyes on the patients. We provide helping with the ADLs, helping with the personal care of the patients, and supplies, which we'll talk a little bit about later, as well as medication. But again, the focus is on palliation and comfort. The focus is not curative in nature. So some of the challenges that we face is the coordination of care. And that's difficult anytime you're trying to coordinate care because everybody's busy and they may not always have the time to stop and learn kind of what the hospice has done or what they're seeing. So it's very important that we have coordination of care and that we have proof of that. So hospices should be attending your care plan meetings whenever you have those. If you're not having them now in person because of the weirdness of the world that we live in, then they can call in and do that. They should also be relaying that information to the patients and families. And it's very important that we are both on the same page with what we're doing so we're not providing contradictory information to the patients and families. So communication is huge. We have to agree upon what the hospice is providing and what the nursing home is providing. So because hospice is there, that doesn't change the responsibilities of the long-term care. You're still responsible for the day-to-day. Hospice is more of an intermittent level of care, and like I said, an additional layer of support. We have to make sure that we're responsive to the needs of the residents, and we have to be knowledgeable and attentive to the regulations of each other. So what does hospice provide? We provide skilled nursing, we provide social services, we provide physician services, we provide chaplain services, we provide aides to help with the personal care. We also have volunteer programs. And like right now with Veterans Day, our volunteer program is going around and recognizing all of the veterans that we have on our service, which is really nice. They get presented with a pin, a certificate, and a small gift to thank them for their service. We also will do things for Mother's Day. We'll do things for Christmas, all of those things. And most of that is done through our volunteer services. So what are some of the benefits of hospice? Again, hospice is really specialized in pain and symptom management. Our physicians are specialized in pain and symptom management. Again, like I said, to focus on palliation, that we have one-on-one emotional support, not just for the hospice patient, but also for the facility staff. We do recognize that oftentimes, facility staff becomes very attached to their residents. And so it can be difficult. It can be like losing a family member whenever this happens. So we're here to provide that emotional support for both the resident, family, and facility staff. Also, there's a little bit of financial relief. So the hospice pays for medical equipment, like your beds, your specialty beds. They pay for medications related to pain and symptom management related to the disease process. They pay for medical supplies like briefs, wipes, all of those types of things, all that's related to the terminal illness. And then also increased interaction. You guys have a ton of patients in your facilities. And so sometimes it's difficult to spend that additional time. And so that's what we're there for, to help with as well. What does it take for a person to be eligible? They have to be diagnosed with a life-limiting illness, a life expectancy of 6 months or less, which is determined by the physician and the hospice interdisciplinary team. And they have to be seeking palliative care rather than curative care. They have to understand that life-prolonging procedures are not consistent with hospice care. And the hospice services have to be approved by the attending physician and the hospice medical director. So it takes 2 physicians to certify that the patient has a prognosis of 6 months or less. That can't be determined by the nurse that goes out and visits the patient. That can't be determined by the person that gathers the legal documents. It has to be determined by 2 physicians. So Medicare came up with these fantastic things called our local coverage determination. And these guidelines are not law, not regulation, but they are tools to help determine the prognosis of a patient or family. So there are multiple local coverage determinations that are available to use to determine that prognosis. Some of the ones that are available are lung disease, like your COPD, heart disease, your CHFers, your vascular disease patients, renal failure, your HIV patients, your stroke patients, your dementia patients, patients who have cirrhosis or liver failure, your patients with ALS, and then your cancer patients. Also, there are patients who may not have all of this stuff. Sometimes people don't fit into the local coverage determination. And so that's where we have to really kind of think about what it is. If you have that patient that has a lot of weight loss because they've just decided that they're going to stop eating, but they don't have dementia, they don't have heart disease, they're just declined, and we don't really know why. So that patient they still be eligible for hospice. They don't necessarily have a LCD or local coverage determination for that. But we're able to get the 2 physicians, if they agree that the patient has a prognosis of 6 months or less, these patients still get care. Medicare recognizes that you can't put a square peg in a round hole, and so they make adjustments for that. Core services, we do this in collaboration with the long-term care facilities. Physician services, our medical directors typically fall over pain and symptom management. Some physicians that are the attending physician may choose not to remain involved in the care of the patient. That's totally up to them. And they may hand the primary over to the medical director for the hospice. Nursing services are provided by both RNs and LPNs. Some hospices utilize RN only. The nurse's responsibility is to communicate and coordinate with the physician in the long-term care facility, to be aware of what your protocols are for coming into your facility and who they need to communicate with, for helping the physician to determine ongoing eligibility, to assess the skin, to provide wound care, all of those things the nurses do. Medical social services is a service provided to where they work a whole lot with helping place patients in long-term care facilities or assisted livings. They work a lot with the families, the POA, to help with end-of-life arrangement planning, whether it's funeral home, whether it's advanced directives or a do not resuscitate order. We have a situation right now to where they're working on getting a TV to a patient who has moved and doesn't have a TV in his room. So they're trying to figure out how they can get the transport set up. So a multitude of things, getting family members into town to visit. You know, if you have an incarcerated family member, sometimes that can be difficult. So they will help coordinate all of that. Spiritual counseling, our chaplains come in and provide that additional spiritual support. They are not there to take over the family's church. They are not there to lead them into what their faith is. They are there to walk alongside them in this journey with end of life. So they are there to meet them where they are and to provide support, whatever that looks like. Bereavement counseling, this is utilized after the patient has passed. And this is support that lasts for approximately 13 months. Not everybody wants it that long. Some family members say, hey, you know what, we're good. We've already grieved mom. But they are there to do that. Our bereavement counselor, he's also a licensed counselor, in addition to us working and specializing with loss and grief. He does one-on-one sessions with family members. He will go to them where they are, go to the house and coffee and visit with them. Dietary counseling, so that is what it is. That is exactly what it sounds like. So to kind of help determine what the nutritional needs are with that patient and family. It doesn't come up that often at end of life, but should it come up, we do nutritional assessments on all of our patients. So should that come up, dietary counseling is provided. And then the volunteer services that we discussed. Collaboration is incredibly important. We see the patients intermittently. Your staff sees them every single day. So it's very important that we collaborate services that help prevent duplication of services, but also to enhance the care that that patient is receiving. We are available 24 hours a day, 7 days a week. We have a nurse on call at all times. We are available on the holidays. So anytime you have a situation, for example, if you have a patient that falls, when they're on hospice, then the goal is to call the hospice instead of calling 911, get the hospice nurse out there to evaluate the patient and see, work with the physician to see what the course of treatment is going to be. I want to kind of go back a little bit to when we were talking about giving up hope. I think that there's some myths out there that hospices don't treat infections, that they don't provide oxygen, all of those things. We do still treat infections. We do still do diagnostic stuff. We do provide oxygen. If the patient we suspect has a pneumonia, we may treat it without getting the chest x-ray, or we may go ahead and get the chest x-ray. We have access to portable x-ray systems, but we do still treat those things. It's, you know, like I said, not about giving up hope. The hospice team is available not just to the patient and family, but also to the facility staff, which we kind of talked about. So if you have a situation where you've had a lot of loss in your facility, for example, that can be very, very difficult on the staff. So our bereavement coordinator and our counselors are available to the staff as well to help support them through this loss. So the responsibilities, the long-term care responsibility doesn't really change. Their actual patient care responsibility doesn't really change. They are still responsible for the day-to-day care. Our nurse will coordinate the care plans and make visits, as well as working with education, staff, families. They should be looking at all the records, and then they will supervise our aid services. So in the state of Oklahoma, a hospice aide has to have an RN supervise their visit every 14 days. So that's the responsibility of the hospice. One thing that really helps a lot with hospice is the coordination of care with family members. Some family members don't understand, or maybe they haven't seen their loved one in quite a bit of time. So the hospices are able to kind of help bridge that gap a little bit. So all that responsibility doesn't fall on the nursing home staff or the long-term care staff. It should be a collaborative, easy for me to say, relationship. We leave notes in the long-term care facility. We leave our plans of care. We should be working with MDS coordinators. We should be working with administrators, with the directors of nursing, with the charge nurses, to make sure that we are meeting that regulation for both of us on coordination of care. That's one thing that surveyors look for in both long-term care as well as hospice, to show that we do have that collaboration. So we want to make sure we're doing that. The physicians, the attending physician oftentimes will continue. It does not change just because the hospice medical director may be overseeing the patient care. It does not change that responsibility that the attending physician or that the long-term care physician sees that patient. They still have to see that to meet that requirement. The hospice medical director does not take the place of the attending physician as far as long-term care goes. So there's no given that regulation. Even if the family chooses to utilize a hospice medical director, which does not happen very often in facilities. They want to stick with the facility medical director. And then the hospice medical director is a resource for everyone on palliation.
How do y'all get paid?
We get paid by Medicare. So the question was, how do we get paid? We get paid by Medicare. And so we accept whatever the Medicare reimbursement is. So we get a set fee every day, a per diem rate every single day by Medicare. And out of that rate comes all of these services. So your nurse's salary comes out of that, your home health aide, social worker, chaplain, physician, medications, medical supplies, medical equipment, all of that comes out of that daily rate. But we get paid by Medicare and our patients don't receive a bill. So whatever, we accept whatever that payment is for us, for our company anyway. Each company has the option not to do that. In the state of Oklahoma, unfortunately, there's not a Medicaid hospice benefit. So those patients who have Medicaid only, there's no reimbursement for the hospices for that. So some hospices, including us, will take some pro bono patients to kind of help fill that gap because those patients really kind of get left out in the cold. It's incredibly unfortunate. That hospices have been lobbying for a long time to get a hospice Medicaid benefit in the state of Oklahoma, but to date it's been unsuccessful.
Really?
Yeah, it's really, unless you're a pediatric patient. So pediatric patients can receive that. But we also accept a lot of insurance. So we just get the prior auth and do that for insurance stuff. But yeah, there's no Medicaid benefit whatsoever for hospice, which is ridiculous, but it is what it is right now. Collaborative relationship, each provider shall identify lines of communication for the medical care. So it falls on the hospice responsibility to find out who that line of communication is going to be with in the long-term care facility. So do we need to check in and out with the DON? Do we need to check in and out with the administrator? Is it the charge nurse? Kind of who is the decision maker? And who is it that we need to be coordinating those services with? So all of our care is provided as agreed upon by the plan of care, as long as it falls within our regulation. Our social workers, spiritual counselors, dietary, bereavement, and other counselors are there to provide the spiritual and emotional support for the residents and families, as lined out in the plan. So what that means is, well, it doesn't mean a whole lot. So the plan of care can change. That's a living, breathing document of it. So if a patient needs more social work service, if one patient needs more social work service than another patient, it's not cookie cutter. They can get that. So that is a living, breathing document. So if you guys identify an additional need for a patient that's on hospice, you need to communicate that with the hospice that you've identified this, and they will provide that additional support. Again, it's a collaborative relationship. You'll hear that word collaborative throughout my whole entire presentation, just because it's incredibly important. It's incredibly important that we have open communication between each other, and that we communicate any changes in the patient's status that could possibly affect the plan of care. So who can refer to hospice? Anybody can refer to hospice. So you may have someone designated. It could be your MDS coordinator. It could be your DON. It could be anybody that those referrals come through. But anybody can refer to hospice that's involved in the patient's care. Sometimes it's very difficult, and it's been found that long-term care staff are really sensitive to the residents of hospice. One thing that can be a barrier to patients getting hospice care is, as we know, like for example, with an Alzheimer's patient, it's a pretty slow decline. Most often, it's a pretty slow decline. And so sometimes it can be very difficult to identify those patients because you see them every single day. And so when you see someone every single day, you don't notice necessarily when that decline is. One thing I will say about that is the earlier the referrals, the better it is for the patients and families, because whenever we only have them for a couple of days, we don't get to do as much education and training with them as we do if we have them for a few months. So some of the things that you look for specifically with Alzheimer's dementia patients is you have patients that have urinary tract infections, or maybe they've had increased falls, or maybe they were able to walk and now they're wheelchair bound, or perhaps they were wheelchair bound and now they can only propel themselves with their feet. They're not able to operate the wheelchair. Decreased appetite, weight loss, all of those things are some of the subtle things that become normal, but that are actually indicators for hospice care. So, and again, you can refer at any time. If they're not eligible, we'll continue to follow them, but you can refer to these patients. You can refer to these patients at any time. It is the patient's right to have hospice. Sometimes in some facilities, you will have people say that they feel like they're double dipping for hospice because you guys are getting reimbursed mostly by Medicaid, typically by Medicaid, and then we are getting reimbursed. It's not double dipping. It's two different services. And it is the patient's right to have hospice. That is their complete and total right to have hospice. The hospice is a Medicare benefit that was established in, I just lost the year. But anyway, it's only been established like 20 years ago. It's not an old benefit. It's been provided longer than that, but Medicare just recognized it about 20 years ago. But it is the patient's right to do that. That is part of the benefit that they paid for. So the long-term care staff will help to identify potential hospice patients. Once you have made a referral, then the hospice will have some legal paperwork for the patient and family to fill out. This includes consents. It includes election of the hospice benefit. It includes release of information. So there will be paperwork that has to be coordinated for the family or the patient to complete. We have to collaboratively obtain a physician's order for the hospice. So oftentimes that is done by the facility as they will contact their physician and see if it's okay to write that order for hospice evaluation and potential admission. And then we have to educate the resident or whoever their power of attorney is or next of kin is that we have made this referral and that this is what's going on with their loved one. Then at that time, patients have the right to choose. We can't take that right away. So at that time, then typically the long-term care facilities will provide a list of what hospice providers are in their building or that they work with, and the patients and or family will choose which hospice provider that they want to go with. So they have the right to choose. You will then contact the hospice provider and they will set up a time to come out there and do the evaluation and meet with you. And make sure that they have signed that release of confidential information so we have access to their medical records to help determine what the prognosis is. So the long-term care staff will then provide the hospice with documentation. Then you will notify your business office of the change. And then you will notify the MDS coordinator of a reassessment for significant change. And then let the hospice company know when your care plan meetings are so they can help attend those. So what does the hospice do? The hospice provides that information for the facility to give to the patients and families. We have to be responsive and we have to work within the guidelines to determine eligibility and report those findings to the attending physician, the facility, and the patient and family. So once that referral is made and once everything's been notified on your end, we're going to come out, we're going to meet with the patient and or the family, we're going to get the appropriate paperwork signed, and we're going to have a nurse come out, evaluate the patient. They will call the attending physician, they will call the medical director, and they will call the family with their findings. So the hospice will do all of those things, as well as let the long-term care facility know this patient does qualify or this patient does not qualify at this time. Sometimes patients kind of fall in a gray area to where you look at them and you're like, they're really, really close. The nurse cannot make that determination. They have to get with the attending physician to see what that is. They may have to get additional records to kind of help determine that prognosis. The hospice staff will make sure that there's an order for an admission. They will explain what the benefit is, what is in there. They provide a complete list to the patient and or whoever their next of kin power of attorney is of what is covered under the hospice services, as well as what is not covered under hospice services. We check their benefits to make sure that they have Medicare. One of the reasons we have to do that is Patients, hospice is paid daily, like I said, but there are certification periods. So certification period initially is 90 days, and then it goes another 90 days, and then it goes to an infinite amount of 60-day certification periods. Hospice has a requirement whenever it hits that third certification period and beyond to provide a face-to-face visit by a nurse practitioner or by the physician. So that's one reason we need to know if they've had hospice before so we can coordinate that. Some patients transfer from one hospice to another hospice. They change their mind and they want to change companies. There are certain processes that have to be followed for that. So we check the benefits, and then whenever we look at that, it kind of gives us a picture of the patient, what's going on. We also check to see if they're on home health, because if they have home health for something that is not related to their hospice diagnosis, they can have both home health and hospice. But we have to coordinate that with the home health. So we get all that information whenever we're checking eligibility. And then we're going to notify the long-term care facility that they have elected their hospice. Any questions so far? Am I talking too fast? I do that. All right. So Medicare requires that we have a contract with each other. So it can be a one-time contract, a per patient contract, or it can be an ongoing contract that's renewed annually. So we have to have a contract on that, again, defines the services that are provided by each entity. We have to be aware of changes at all times, and we have to modify that plan of care to reflect the changes in the needs for services. Oops. Too far. We have to make sure that our plans of care show that collaboration and that shows that coordination of care. We have to have measurable objectives with timelines on that. We have to have problems, goals, interventions, and we have to say who's responsible for each one of those. So is the long-term care responsible for this goal, or is the hospice responsible? The hospice plan of care has to address pain and symptom management. It has to address preparation for death and bereavement. And end-of-life tasks. So if a patient doesn't have funeral arrangements, our hospice plan of care has to address that. And we work towards getting those funeral arrangements done, so it's not a scramble at the last minute. Also, preparation for death, we have to provide the education to the patient and family members, as well as the facilities, on the signs and symptoms to watch for a patient who is actively dying. Obviously, we address the pain and symptom management. And then the bereavement assessment. So a bereavement assessment is done upon admission, and that assessment is updated as the patient and family journey goes on and after the patient dies. So they're classified whether they're high, moderate, or low risk bereavement at the time of admission. So with the integrated plan of care, hospice retains the overall management of the plan of care related to the terminal illness. Again, that is coordinated, but it ultimately falls on the hospice to provide that coordination. So again, with the plan of care, the hospice, the long-term care facility will provide the physician's orders, the comprehensive assessment from the MDS coordinator, care planning, medication list, durable medical equipment list, social services notes needed to initiate a palliative plan of care. At that time, you will modify your care plan to reflect that the palliative wishes are and that they started hospice. You will continue to provide daily care and communicate any changes in the condition or need. And you will let the patient and legal guardian know and hospice of scheduled patient care plan meetings. The hospice staff provides the initial nursing assessment, completes the guidelines, those local coverage determinators that we went over, completes those. It's a medication list indicating whether we pay for it or whether their insurance pays for it or private pay. This physician's order certifying the 6-month prognosis. Again, that certification has to be by 2 physicians and does their plan of care. So they reevaluate each certification period. So once a patient comes on service, if they're in their first certification period, then it's reevaluated at 90 days. Then the second certification period is reevaluated at 90 days, and then it's reevaluated 60 days thereafter.
Oh.
So to kind of talk about that a little bit, say a patient had previous hospice and they were in their first benefit period, their first certification period, then they decide that they don't want hospice anymore, so they come off hospice. Maybe they only use 5 days of hospice the first time. They decide that they want hospice again, they come back on, they're automatically in their second certification period. So every time a patient revocates their hospice benefit or revokes their hospice benefit, then that certification period ends and they go into a new certification period. So it can be, you can have a patient who hasn't had very much hospice and is in their 9th certification period. So that's what we check with all of those benefits going on. Hospice assumes the case management of the terminal condition. So that doesn't mean that we assume all of the case management. We just assume what's related to what they are on hospice services for. Hospice staff also does our documentation, which is reflective of a hospice philosophy, management of pain or other uncomfortable symptoms. We participate in the care plan meetings and assist the facilities in establishing a palliative care goal. So whenever someone elects their hospice benefit and a palliative care plan, that changes both of our care plans.
Ma'am,
Yes.
I'm sorry, when you turn your head to look at the screen, it's hard for us to hear you. You break up.
Oh, okay. I'm sorry. So we established a time to initiate that plan of care. We have 24 to 48 hours once that plan of care has been established. Once those legal documents have been signed, we have 24 to 48 hours to get that plan of care done. We collect data. We gather, like I said, the medical records. We're going to gather weight. We're going to ask for any changes in condition. We're going to ask for medications that they're currently on. We determine what their medical equipment needs are. Do they need a specialty mattress? Do they need a different type of wheelchair? Do they need gel cushions? Kind of what is that? What does that look like? As well as medications. Again, we don't come in and stop all medications that a patient has been on. We don't come in and stop all treatments, but it has to be palliative in nature. So if you have so sometimes there are medication changes, and that's in collaboration with the physician, the family, and the long-term care facility. An example of a time that medication might be recommended to stop is if you have someone with end-stage cancer who is actively dying, do they need that cholesterol medication? Or is that just another medication that we're giving? And so we look at all of that and we look at what we're doing from a palliative standpoint, as well as what treatments are needed. An example of this is with wound care. So you have a patient, a lot of patients when they're on hospice, their nutritional status has dropped significantly. Their albumins are low, they are less mobile, and so you have someone that has a wound. If you were going to do aggressive treatment for the wound, you might do it every day, and you might do things like sandhill and some of those sorts of treatments. Whenever we're going into a palliative mindset, we're going to do the wound care for palliation. So we're still going to do the wound care, but we may not be as aggressive with the wound care because our goal is for it not to cause pain and not to cause any sort of discomfort. So we don't want to see it get worse, but we recognize that with low albumins and stuff like that, we may not be able to get it cured as well. So that's an example of a treatment that may change. But again, that's in coordination with the long-term care facility as well as the physicians and an interdisciplinary team. We're also going to designate who's on first. So what are you guys doing? What are you guys providing? And what are we providing? And make sure that we're meeting the needs of the patient comprehensively between the two entities. And again, identify the payer source. So together, we are going to develop that plan of care and implement it. We are going to communicate with one another. We are going to communicate with the patient and families and physicians and make sure that we have clear goals and that we have communicated that with everyone. So communication, collaboration. Physicians' orders, the physicians have to participate in the plan of care. Everything that is on that plan of care has to be signed off by a physician. The plan of care is provided to the attending physician and it's provided to the hospice medical director. That includes anything from how many times a nurse or an aide or a social worker or a chaplain sees a patient. All of that is signed off by the physician. A hospice, we talked about this a little bit, but they may elect a different physician whenever they come on service. And choose not to go with who has been their attending physician. The hospice is responsible to everyone for communicating that. and communicating the disease progression, what our plans of care are, and any terminal illness orders. So we are responsible for that. So if we get an order from our position, then it's our responsibility to communicate that with the long-term care facility, which is very important, because if one hand doesn't know what the other hand's doing, we're not getting the whole picture taken care of there. And then again, providing that the documentation is there. Just kind of on a side note, so the way hospice works is the team, the nurse, social worker, chaplain, everybody, the physicians, we meet every 14 days and go over every patient that is on there. So we have an interdisciplinary group meeting a minimum of every 14 days. So at that point, you should be getting notes related to what that interdisciplinary team had determined for that palliative course of treatment and that plan of care. So they meet every 2 weeks, and they go over kind of what we're doing, what our goals are. Do we need to set new goals, have some of the issues resolved, some of the problems resolved, and kind of what's going on with that. At that point, then they will communicate that information with the long-term care facility, the facility physician, if it's different than the hospice medical director. We have to make sure we remain in compliance with the state and federal regulations. We have to notify everybody again of the physician's orders, and we have to communicate those changes in the physician's orders. So that's a two-way street. We're going to notify you if we have a change in orders, and you're going to notify us if you have a change in orders. Hospice, I'm sorry?
Does it happen a lot that you don't get that communication?
It does happen a lot. It does happen a lot. So, and it's not a suggested thing, it's a requirement that we have that communication. So it does happen, unfortunately. A lot of that communication, it falls on both parties, but that's why you have to have a good relationship with the hospice provider that you're utilizing to make sure that that's there. And that's why the hospice has to be proactive in knowing who they are supposed to be communicating that information with in the facility. But unfortunately, it does happen. We have a dog. We have a dog. It is a big dog.
Ma'am,
Yes.
what happens if there's let's say the two doctors have a conflict of interest, or not conflict of interest, but they don't agree with each other? Who has jurisdiction, or who overrides the other one?
The attending overrides.
Okay.
So the attending will override that. If the attending chooses to remain the primary physician in the patient's care, the medical director basically functions as a consultant, but the attending overrides it. Any other questions? All right, so I talked a little bit about our IDT, and then the long-term care staff jointly decides the relationship of all physicians' orders, treatments related to the resident's terminal illness, and then they make recommendations for palliation. So a lot of what hospice does, we are guests in your home. We are always guests in your home. We're not there to take over. We're not there to think we know how to do things better. We are there to be respectful, to be mindful, and almost function kind of as consultants. So we're going to see the patients. We're going to be proactive in advocating for our patients, but we're going to work with you to make sure that that's what's going on. And at the end of the day, the long-term care facility trumps the hospice. So if there's a disagreement, the long-term care facility will trump that. And then we have to abide by your policies, and you have to abide by our policies, is kind of the way that goes. Medical records. So this kind of varies in some of the long-term care facilities. We keep a chart in each one of the facilities where our nursing notes go in, our aid notes go in, social work chaplain notes, our meetings, our med profiles, all of that is provided in there. It's up to you how long you want to keep that stuff. It's up to you when you want to thin that stuff out, how you want to handle those medical records in your facility is up to you. As a hospice, we will continue to retain them. So 7 years after death, we will continue to retain those hospice records. It's important that we have confidentiality of those records. So they're not readily available. Oftentimes they're kept behind a nurse's station where the other charts are kept. Sometimes there's a secure cabinet in a medication room, but it's up to you wherever you choose to do And then we have to have the consent to release information in order to give that information to anyone outside of that. Again, we are bound by long-term care regulations, and your records should also be available to us. So we encourage our nurses to review those charts each time they come in case there was a new physician order, in case perhaps a patient had a fall and was sent to the emergency room and the hospice wasn't notified. All of those things, weights, medication changes, all of those things we encourage them to have. So those records need to be available to the hospice. The hospice, again, is required to keep those medical records and to provide additional documentation, as well as our goals and interventions. All of this information should be kept in the chart, and we decide where that should be. Not we, the long-term care facility decides where that should be. Again, determining the best method to communicate, knowing who to call at hospice. That's a hospice's responsibility to provide you with who to call. Make sure you have the number to call us. System defense charts, which we just talked about. So kind of what is it that you want to do? How long do you want to keep them? How thick do you want them to get? Because some of these patients are on hospice for a hot minute. And then anything that we need to do, and this doesn't really affect us for timely Medicaid billing because hospice doesn't bill Medicaid in Oklahoma, but anything we need to do to coordinate that. Just because a patient chooses to have a tube feeding or IVs, or maybe they want occupational therapy or physical therapy, they can have those things while on hospice. Related to the tube feedings, we don't provide that formula. It's the same as if we providing groceries, you know, it'd be the same as providing any other meal. So we don't provide that formula, but that can be a part of the hospice care. And that's determined by the hospice interdisciplinary team, again, is that palliative. So with physical therapy, oftentimes you'll see these patients go in a skilled facility. Maybe they broke their hip, or maybe they've just had a lot of weakness. So they'll go on the skilled side of the facility, and they'll be receiving aggressive physical therapy for that with the goal of improvement. With hospice, when we do physical therapy, it's a goal of education primarily, and educating people kind of how to transfer the patient safely, making sure that if they need to sit to stand, they have that, or Hoyer, they have that. Teaching range of motion exercises, but it's not really that aggressive physical therapy with the same goal as what there may be in a skilled unit. And then the hospice and the attending physician, along with the IDT, has to determine that those are appropriate. Long-term care can always recommend that they have those services. Oftentimes what we do at Humanity is we coordinate that to where we pay you guys for those services. So if your physical therapist or occupational therapist is going in, we first try to coordinate that with you, and we pay Medicare allowable rates. So it may not be what you would normally charge, but if you guys are cool with that, then we'll utilize your therapy services. If not, we have our own therapy services that we are contracted with that we can provide. So in order for therapy services, we have to have a physician's order. We have to have our goals. How long do we think it's going to last? We have to keep their personnel records. So if we are utilizing your therapy services, we have to keep a soft personnel file on them showing that we have their updated licensure, showing that they've got their background check, all of those things that we have to do to employ people. We have to keep a copy of that as well in our charts. And then required orientation and ongoing in-services. So any sort of orientation that you guys have done, if you can just send out orientation plan, that's greatly helpful. I don't know if you have a PowerPoint or whatever that looks like, to show that the orientation was done and any ongoing education you've been providing. So we both agree upon the scope and frequency of services. We monitor what our outcomes are with those services. Do we need to continue that, or have we reached our goals, our palliative goals? And there has to be, again, a mutually agreed upon method to provide those services. Our loss and grief services. So we talked a little bit about the bereavement program. It is available to patients, families. It's even available, like I said, to the long-term care staff. So if you guys need that, reach out to whoever the representative is from the hospice company that you've been working with, and they can set up to do group grief support. There's been situations to where a staff member has been lost, and the facility staff is suffering with grief, we can provide counseling for that. So it is readily available. If you guys notice that a patient's family member is really kind of struggling with this, maybe you have a daughter who lives out of town who can't get to see mom, or like right now with COVID, very few people can get in to see their mom. So if you see those high-risk people, communicate that with your hospice provider so that they can get that counseling service out there. And we do those ongoing assessments to kind of see where they're at. You know, sometimes people are really high bereavement risk when they initially come on, but as the team works with them, that bereavement risk changes. So we keep that bereavement care plan updated. Again, we have a joint care plan that we're working on. Long-term care staff provides grief support as well. The hospice providers provide education and identify community resources. Our counselors, like I said, do the one-on-one. But if you have someone who is out of town, like a long distance away to where they can't get to them, then they will find resources for them to get that support. And we determine that together. So you guys help us determine that. At the time of death, this is a very, very crucial time. This is kind of what we are there for, right? So at the time of death, we have to notify who's responsible, or determine who is responsible to notify the physician. And some facilities, they want to notify the physician, and others, they just want the hospice to come in and take care of it and get it done. As well as we notify the pharmacy, the mortuary, and the coroner in Oklahoma County. We have to call the medical examiner to get that order to release the body. So whenever someone dies, or whenever you see that they're getting imminent, then you contact the hospice, and the hospice will come out there and respond to that. We also are there to, you guys are there to provide support for the patient while we're en route, family and staff. And then we will decide together who is going to notify the patient's family members. And oftentimes that's based on relationship with the family members. You know, if you have someone who hasn't been on hospice all that long, but who has been in the facility a long time, someone in there may choose to contact that family member, but that's just a collaborative decision that's made. You will destroy medications based off your protocol. You will determine what your death protocol is, and you will follow that. And then you will notify us at the time of death. We will make a visit, and again, we're available to provide the counseling services. We will assist with the arrangements going on. We will assist with the postmortem care going on. All of those things we're there for. We're more than happy to make any of the calls that need to be made, make any of the notification. A bereavement coordinator will get involved, and then we will notify the rest of our team about the time of death and funeral arrangements that were made. Together, we're going to ensure that the needs are addressed and met. We're going to support the family members following our protocols for dealing with difficult behaviors, which we all deal with difficult behaviors from time to time. Oftentimes, it's very important that we attend those funerals together because that helps give the family closure. We've been a part of this journey with them, and so it can be very difficult for them whenever we just all of a sudden are gone. And then the hospice will provide ongoing support to the long-term care staff and residents. I had a resident one time who was really depressed and really declining. It was one of my hospice patients, and there was no physiological reason for what was going on. Well, come to find out, they had had 4 roommates die in a period of 6 months, and it had really taken a toll on that person. So helping to kind of identify that and recognize that and provide support to that resident is really, really critical. And I can't imagine now what they're going through. We want to make sure that we are consistent. So hospitalizations.
Good question.
Okay.
At what point do you start continuous care?
So there's 2 different things. There's 2 different parts to that question. At what point do you start continuous care? So continuous care is a term that's used a lot of times. We don't really understand what it is, or a lot of hospices call it continuous care. There are 2 different things that we do at the time of death. Continuous care, if the patient is in a crisis, that's where a nurse stays at the bedside for 24 hours. If it is a normal death, which is an expected outcome, it depends on what the facility wants. So typically, whenever we start seeing those signs of imminence, meaning that we think we have about 24 to 48 hours left, we will initiate that support care for that patient. So if it's a normal, peaceful, calm death without symptom management, we do support care. If it is a crisis type situation, we do continuous care, which is more nursing driven. So support care can be provided by the chaplain being there. They rotate times coming in, you have a schedule, but typically it's about 24 to 48 hours. Is that it? All right. Hospitalizations. So our goal in hospice is to prevent hospitalizations. I like to tell people we are now your 911. So if you have anything, like I said, if you have a fall, if you have a changing condition, contact us first. If the patient has to go to the hospital, we want to make sure that we're able to follow them and that they don't get lost in the system and that they're able to come back on services when they do. Not all patients that go to a hospital have to be discharged off hospice services. If it is not related to their hospice diagnosis, they do not have to be discharged. If they go to the hospital in a crisis, the hospice can get a contract with that hospital to continue to provide care while they're in the hospital. So it's not an automatic discharge. Most of the time it is a discharge because most of the times that they go to the hospital is for a fall related to their hospice diagnosis or things along that line. So it's important that you guys contact us whenever you have a patient that you're sending out to the hospital and hopefully give us that time and opportunity to get there and respond so that we can work with the patient and see if we have other options other than hospitalization.
So like, what if you have like someone that got sent to the hospital for, I don't know, heart issue or whatever, but, or that had a diagnosis of heart issue, but they sent them for, I don't know, something to do with COVID.
Yeah, so the question was, what if you have somebody who has a diagnosis, a hospice diagnosis of heart issues, but they send them to the hospital with COVID? That would be not related. So that patient could remain on services. Yeah, but if that same patient goes because of fluid overload, then that would be related.
Right.
Yeah. COVID is a weird thing because it's not really related to much of anything,
That can be a thing.
but it can affect it.
You don't know until it happens.
Right, right. We don't really know. And we do follow those patients in the hospital just to kind of check with them and check up on them, especially now with COVID going on, so we can help communicate with the patients and the family members, or help communicate with the family members who may not be able to see their loved one while they're in there. Also talking a little bit about COVID, something that we do at Humanity is we FaceTime our family members when we're making our visits or Zoom call them so that they can see their mom or dad or husband or wife or whatever the relationship may be. So really trying to kind of support that. It's just such a strange, sad time right now with all this going on.
How has making relationships with long-term care and keeping open communication changed since COVID?
So the main change that we've seen is there are some facilities who aren't allowing hospices in. So we're having to do a lot of the coordination of care via Zoom meeting or FaceTime or those ways. So that's the main thing. And that's been a challenge with coordination of care for sure. Because us not being able to lay eyes on the patients. I mean, there are times that we have a situation today where the patient is being admitted to our services. We can't physically lay eyes on them. So we are very dependent on the facility to give us all that information. And then we're doing a Zoom admission. It's just really weird. So that has changed significantly. And then, you know, you'll have a facility who lets you in and then all of a sudden they don't let you in. So you're trying to coordinate care with that facility and with the family members, and it's just very difficult. So that's primarily how it's changed with COVID.
Well, I think it's a lot of communication with our nursing, with our teams, with the long-term care facility and letting us know what we need to do or what has changed. It's like we had a change yesterday that a place has a COVID positive patient, so they have locked down everything. And so just communicating back and forth with what their expectations are and what our expectations are very key.
Yeah. Absolutely. So again, with hospitals, we want to determine the emergent need. We need you guys to contact us and let us know what's going on. We need to contact the family member as well as our physician and your physician. Sometimes we may be making arrangements for transport. There are times that transport falls on the hospice responsibility to make those arrangements. If it is unrelated, then it falls on the long-term care staff to make those arrangements. And then getting the discharge orders falls on the long-term care staff whenever the patient's coming coming back. We are to, as a hospice, we are to respond to the long-term care staff, provide emotional support, send a plan of care, any advanced directives, medications. And like I said, we may continue to provide treatment if it is related to the hospice diagnosis. If it's unrelated, then we continue to provide routine home. And as soon as their symptoms are controlled, our goal is to get them right back to you. So we want to, again, make sure that everyone knows that the patient is on hospice. It happens more often than you would think that something happens in a long-term care facility, and the one person who's working that weekend night shift doesn't know that the patient's on hospice. So we need to put it all over the chart, to call hospice, and get that done. It's important that both of us know if the patient is a do not resuscitate, or if they are a full code, because that changes whether or not they go to the hospital, right? So it's important that we both know that we have copies of that, and that we are abiding by their wishes. We'll talk to each other about whose responsibility it is to get the updates. If you guys want the hospice to get the updates on the patient's changing condition, we'll contact the hospital and get those updates, or if you guys are going to do that, then just let the hospice know and provide them with those updates. And then we have to change the plan of care, both of us. So there are just a handful of reasons that hospice services would discontinue. If a patient chooses to no longer receive hospice care, maybe a reason that they discontinue. If a patient is no longer eligible to receive hospice care, is a reason they would discontinue. If a patient chooses to have another hospice provider, is a reason that they discontinue. If a patient, I said no longer eligible, that would be decertification. If a patient moves outside the service area, that would be a reason to discontinue. And moving outside the service area can be entering a non-contracted facility as well. So those are, other than death, those are the primary reasons that a patient may no longer receive hospice benefit. They have the right to revoke their hospice benefit at every time, same as they have the right to elect it. So they can choose to revoke it on Wednesday, and then they want it back on Thursday. So they have the right to do that. So the admission process doesn't change when they do that. We have to go through the exact same steps. We have to get another order. We have to do all the same paperwork, and that's their right. So we want to be very mindful of their right. Again, if they no longer meet that criteria, so if the interdisciplinary team, the hospice physician, and the attending physician determine that they do not have that prognosis of 6 months or less, then at that time, hospice services would be discontinued. And they can transfer services at any time to the hospice of their choice. Respite care. So this is something that we do in long-term care facilities primarily. We don't really do it outside of them. So respite care is utilized whenever a patient, say for example, they live at home and their caregiver has to have an emergency surgery and there's nobody else to care for that patient. At that time, we would contact a long-term care facility and say, hey, we need to place this patient for 5 days until we can figure out something else. And so then we would pass through, Medicare would pay us. You guys would not bill Medicaid. In that situation, they would pay us and we would pass that payment through to you guys. That requires a contract, but that's an example of respite. Or the caregiver just cannot do it and needs a break. That would be an example of respite. So we would contact you guys. We would get whatever you guys needed to do that. And then we would place them in the facility for respite and pass that through. General inpatient care is a level of care that's provided whenever a patient is requiring services that may not be able to be provided at home. There's not very many services that can't be provided at home, but sometimes they may get into a pain crisis and they may require epidural placement, for example. Then that time we may do general inpatient care. This can be done in long-term care facility if they have a 24-hour RN, which most of them don't. But if they have a 24-hour RN, then that's done. And it works the same way payment-wise as respite does, and that you bill us and we pay you. You don't bill Medicaid. So it's paid at a higher rate. The hospice provides the transportation back and forth. We arrange for the admission with the skilled nursing facility, long-term care. We agree upon the contract before the services are provided. And we provide you with any documentation or information that you need for those services. We'll get the bed out there. We'll get whatever equipment is needed out there prior to that. We will continue to provide the same services we were providing in the home. So nothing changes with that. They're still going to get their nurse, they're still going to get their aide, they're still going to get all of those things. We are just passing the payment through to you guys at that point. And then we'll develop a plan of care together. We already talked a little bit about reimbursement. Again, hospices are only required to pay for things that are related to the hospice diagnosis. So, and that are palliative in nature. So we pay for all of that out of our per diem rate that Medicare provides us. All services are paid for out of that. And we do have to pre-approve the services prior to them getting started. So if you have a patient who you're going to do IV antibiotics on or something like that, it's related to the hospice diagnosis, you need to let us know so we can provide the medication. Medicaid, ignore that. We don't have it in Oklahoma. You guys do have Medicaid room and board. And then private insurance, we do contract with private insurance companies. So once a resident has elected, and this is straight out of the state operations manual, once a resident has elected the Medicare hospice benefit, the hospice and the nursing facility must communicate, establish, and agree upon a coordinated plan of care, which reflects the hospice philosophy and is based on the assessment of the individual's needs and unique living situation in the facility. So again, our plans of care have to be living, breathing documents. They have to represent what is going on with the patient at that time. They have to be updated regularly. We have to make sure that our goals and our interventions are very patient specific. There is a registered nurse that the hospice provides to coordinate that implementation of the plan of care. And it must identify the care and services which the long-term care facility is providing and the hospice is providing. And this actually came up on a survey recently to where we had to show proof of that coordination. So we may be providing that, but we have to show proof of that. That's where inviting your hospice to your care plan meetings is really nice because we can show proof that we attended those care plan meetings and that we collaborated together with that. But it falls on the, like for our surveyors, it falls on us to make sure we have that documentation of coordination of care. For long-term care surveyors, it falls on the long-term care facility.
Who gets contacted if there's an issue with like one of your staff members?
So they asked who gets contacted if there's an issue with one of your staff members. In our organization, it would be me as the director of clinical services. I would be contacted. You can contact whoever, honestly, and then they pass the message on to me and I do the follow-up and investigation. But if there's an issue, you contact whoever your contact may be, but always feel free to contact the director of clinical services. They're going to be most likely to resolve it for you quickly. We are responsible for performing our own functions that have been agreed upon. The hospice retains overall responsibility and professional management for the implementation of the plan of care related to the terminal diagnosis. Surveyors, our best friends. We have to show them that the plan of care reflects participation between both the facility as well as us. That we have to have directives for managing pain and symptoms that are revised and updated, and that drugs and medical supplies are provided as needed. We have to show proof of communication to changes in the plan of care. We have to be aware of each other's responsibilities, so the who's on first, and it has to be consistent with the plan of care, coordinated with the hospice. They're going to look to make sure that skilled nursing facilities and long-term care facilities did not change the services they are providing just because a patient came on hospice services. So they're going to want to see that you guys are still doing the same thing you were doing before. But it may be agreed upon that the hospice gives all the baths, or showers or whatever that looks like. Or hospice is going to do the wound care, whatever that looks like in that patient's case. But that has to be documented, who's doing what. So major areas of concern that the surveyors are looking for is that the services don't reflect the hospice philosophy. So that's again where we have to be on the same page of palliation and kind of what our goal is. That we show coordination, that we have a system to monitor effectiveness of the plan of care. And anytime there's poor communication between the hospice and facility staff, that can be an issue. So keeping those records up, showing that we're attending the care plans meetings as a hospice, again, we'll show proof of that. Jamie. Is it still on that? Aha. So as you know, as we went through this, the words I use constantly were communicate and collaborate. Those are the most important things we do. That's going to keep both of us out of trouble. That's going to benefit the patient, the families, the skilled nursing facility, as well as the hospice. So that communication and collaboration is crucial. Any questions? You're good? All right, Tammy, I'm going to hand it over to you.
Woo-hoo. I don't have a pretty slideshow. Take this off so you can hear me. All right, I'm going to talk about DNRs and advanced directives. So if you have questions, say it, print it, whatever, because we want to make sure that we answer those. So a couple things that they are very the same in is they both have to have 2 witnesses sign. They do not have to be notarized. Either one of them do not have to be notarized. Obviously, one is yellow, and sometimes you may have a copy and you won't have the yellow, but to be able to see this and know that you have one without a copy, as you can see that it's yellow. Both can be revoked at any time. So let's talk about the advanced directive first. This is something that pretty much everyone should have because it tells of your wishes that you want if you are incapacitated. So you had a stroke or you had a heart attack, or you were in a coma, a car wreck, whatever it is. So this is something that everybody should have because it lists what your wishes, your medical wishes are. And you sign it, you initial it, you have 2 witnesses. Again, it does not have to be notarized. It also has the option where you can give someone the medical authority to make decisions for your care. And this is in this as well. Again, this is something good. It doesn't mean that this person is your POA, but they do have jurisdiction over your medical decisions if you are incapacitated. That's probably one of the biggest things. This is something that you should have because when something happens, it's already done. So no matter your age, this is something that you should have. And this goes into effect, not when you sign it. This goes into effect when you are incapacitated. The DNR, it goes into effect immediately, the second that it's signed. So a DNR, again, has to be witnessed by 2 people. If you are incapacitated, it can be signed by your family member to say, yes, they told me their wishes, they might not have an advance directive, and you can sign that for them. This is for somebody who is in your long-term care facilities or a member that has been diagnosed and looking at palliative care. You know, hospice has been called in. Because again, this takes effect immediately. You will not be resuscitated. If your heart stops or you stop breathing, you will not be resuscitated. That's what this form is for. So if you have, one of the things that as a hospice, I don't think I said, my name's Cammie and I'm a community hospice. We don't require that there be a DNR, but we definitely try to get one signed. And in doing so, if I'm the person that's the first person that goes out and gets the paperwork signed, that's part of what I do. And if I'm talking with the families or talking with the patient and they're not interested in signing this yet, they don't want to talk about this yet, that's okay. We don't require it for them to come on our services, but we will continue to talk to them about it because what it will look like further down the road, we would rather the family member pass in peace rather than they didn't sign this, they're a full code. We have to do everything in our power to keep them alive if their heart stopped or they stopped breathing. And, you know, at some point that doesn't make sense if they are incapacitated at all. Their life wouldn't be very well if they were hooked up to every machine and then transported from your long-term care facility to the hospital. they would want their family member or they would want to pass in peace. So that's the biggest thing with this is getting it signed, having more education to the family. Our social worker, our nurse will continue to talk to them because we also know that that's something that you would like to have signed in your long-term care facility. But again, it's not required, but we will work on it until, the family understands. And again, there's going to be those patients that never want to sign a DNR. They want to have everything done to save themselves or that family member. And we understand that and we abide by those wishes. So, but again, it's not required to get on hospice. I'm going to go over my notes. There's a couple things I want to make sure that I have said. Healthy person, 2 witnesses. On the DNR, if the person is at home, obviously, we ask them to put it on the refrigerator. If they're at your long-term care facility, we ask that there's a copy that's in their books. We also, do we keep copy in our charts as well?
Keep it uploaded?
Yeah, so we keep it in our charts. We have a big thing that says, they have a DNR, or we have a thing that says they have a full code. On both of them, I said they can be revoked at any time. You can change your advance directive, and the one that is upheld will be the one that is signed the latest. Did you use the word latest?
Most recently?
Most recent, that's the word I'm looking for. And at any time, a DNR can be revoked. They don't want to have it anymore, rip it up, it's gone. A lot of times people believe that because they have an advance directive and it states in there that they don't want to be resuscitated, that they don't need a DNR. And we want this DNR as well, because you might not be able to find this advance directive. The family doesn't have the advance directive, whatever it is. So it's a separate DNR should be signed. And I said that goes into effect immediately. A DNR, like I said earlier, deals with CPR only if your heart has stopped or if you've stopped breathing. One of the things on the advance directive that makes our state different, so if you have an advance directive from another state, it will be upheld here in Oklahoma, but you should sign one that's in Oklahoma as well, because a lot of states don't deal with hydration and nutrition, and the state of Oklahoma does. That is on our advance directive, and that's something that, it's good to know what that person wants. So that's another tip. A person can sign, obviously you sign your advance directive, but a family, if you're incapacitated, then a family member, POA, physician, attorney can sign the DNR. And that is all mine. So I'm open to questions because mine's not very hard and lengthy like Angie's. Does anyone have any questions on either one of them? You can have both, you should definitely, all of us, everyone's talking and watching and listening should have an advance directive. Those when you're dying should definitely have a DNR. Do you have anything you want to add?
No.
Okay. Does anyone have a question? I'm just gonna take it that I covered everything and so no one had a question. Thank you, guys.
I don't know.
Man in charge.
I don't know.
See,